All right, I'd like to welcome everybody and say good evening to you all. My name is Larry Robinson. I'm the current Riverside County Medical Association President-elect. I want to thank you for joining us for tonight's presentation entitled Examining Professional, Personal, and Ethical Boundaries. I want to thank our co-host ProAssurance for providing the presentation. Today's presenter is Mallory Early. Mallory received her Juris Doctorate from Cumberland School of Law at Samford University. Mallory advises practices on professional liability issues, writes articles, develops education courses, and speaks at seminars for physicians, clinicians, and practice administration professionals. Mallory is an active member of the Birmingham Bar Association, the Alabama Bar Association, the American Society for Healthcare Risk Management, and the Alabama Society for Healthcare Risk Management, where she was president in 2020. And now I'll turn it over to Senior Risk Management Consultant Anne Marie Liddy, who will be facilitating the presentation.
Great. Thank you so much, Dr. Robinson. Before I introduce the program, because as you know, this is Mallory taped, the presentation is scheduled for 1 hour. The information contained in the presentation is intended as risk management information, and it does not constitute a legal opinion, nor does it substitute for legal advice. And any legal inquiries that arise out of this presentation should be directed to an attorney. And as Dr. Robinson mentioned, our speaker is Mallory Early, and here you go with your presentation. And I hope you enjoy it.
Let's take a look at the learning objectives for this program. This will give us a bit of an outline as we examine various scenarios and how your own boundaries might mitigate risks with your patients and other clinicians. So tonight's learning objectives are first to explain the relationship between the physician-patient boundaries and professional liability risks. We're going to then also identify a previous encounter where expectations were not met with either a patient or another healthcare professional, and then apply the risk reduction strategies to reduce liability risks and preserve professional and ethical boundaries. This slide shows an overview of the topics we will cover and gives some insights as we navigate through various types of boundary scenarios with patients as well as other physicians. Here's our roadmap for tonight. We'll start with patients and look at 3 distinct areas: sensitive exams and the use of chaperones, prescribing controlled substances, and treatment relationships, such as caring for friends and family in the professional setting. Each of these areas can have exposures for our insureds, but there are risk management strategies that can mitigate these areas of risk. And then we'll wrap up the program talking about boundaries with other physicians and how handoffs and referrals can complicate treatment relationships and even leave room for miscommunications and open yourself up to potential liability risks. Before we get into the meat of the program, I want you to step back and remember one of the most important oaths you took as a physician, the Hippocratic Oath. One version states, "Whatever houses I may visit, I will come for the benefit of the sick, remaining free of all intentional injustice, of all mischief, and in particular of sexual relations with both female and male persons, be they free or slaves." Although stated in a more succinct way, the Hippocratic Oath really boils down to a promise to uphold certain professional and ethical standards as you treat your patients. These standards or boundaries are important as you care for your patients and maintain a sense of personal and professional ethics. As you can see, the prohibition of physician-patient sexual misconduct extends back at least as far in history as the Hippocratic Oath of Cost, which was 5th century BC. Here it is in another wording of the famous oath: "In every house where I come, I will enter only for the good of my patients, keeping myself far from all intentional ill-doing and all seduction, and especially from the pleasures of love with women or with men." Each physician takes this oath at the start of his or her career and holds it true when caring for their patients, regardless of specialty, location, or even length of your career. The Hippocratic Oath raises important points to consider. There are times when a physician may have personal feelings towards a patient. However, it is up to the physician to keep those feelings from becoming any type of sexual misconduct. The central role of a physician's judgment and self-regulation in these matters has been around for a very long time. The Hippocratic Oath is rooted in the ethical principles of practicing medicine with the intent to do good and be professional in all aspects of the physician-patient relationship. As we go through this seminar, I want to challenge you as the learner to reflect on ethical principles within each section of this presentation. Our first topic of the seminar is boundaries with patients and how to handle allegations of misconduct and what you can do to protect yourself by using chaperones. I want to begin this section and each section of this program with a polling question. So please take a minute and answer the following polling question. So you'll see this is only in response to question 1. Do you have a chaperone policy? All right, so on this one, we are split about 50-50. 53% say yes on the chaperone policy, about 47% saying no. So first, thank you for participating. And we can see from these results that we are kind of a mixed bag in the audience tonight. That's why I like these polls. It's just an opportunity for us to be able to see what our audience looks like and what issues you may have in your practice. So thank you for participating in that one. In this section, we're going to talk about the importance of a chaperone policy, such as why to have them, when to use them, and what purpose they serve. Now, you may be wondering, why are we talking about physician misconduct? It cannot be that prevalent. It's not something that really applies to me. Well, you can see that data indicates that most physicians practice medicine with integrity. However, sexual misconduct is one of the most common reasons for medical board discipline. Between the years 2000 and 2019, there were a total of 1,721 reports of physician sexual misconduct to the National Practitioner Database. That represents, on average, an annual incidence of 10.78, so nearly 11 per 100,000 U.S. physician licensees. The true extent, however, of such misconduct remains uncertain due to the assumption that it occurs more frequently than it's reported. At ProAssurance, we often see patient complaints regarding sexual misconduct as an additional allegation to that of a standard lawsuit for negligence or medical malpractice. These inappropriate conduct cases can be added on as a means to add heat to the case, such as not only did the physician provide suboptimal care, but he or she did so in an inappropriate manner. These allegations of misconduct are not uncommon and have seemingly increased with very publicized cases. Some physicians have used poor judgment and self-regulation in very shocking and highly publicized ways. Consider, for example, Larry Nassar, who was the former doctor for USA Gymnastics and sports medicine physician at Michigan State University. He had more than 150 women come forward at a sentencing hearing with testimony when he pled guilty to charges of criminal sexual conduct and federal child pornography charges. Another example, George Tyndall, who was a gynecologist at the University of Southern California and had sexually abused and harassed students at USC. He actually banned chaperones from his examination rooms. There's also Robert Hayden, who was the former Columbia University OBGYN, who was accused of sexually abusing dozens of patients for more than 2 decades. These high-profile cases have brought to light sexual boundary issues surrounding the physician-patient relationship. Cases like these and victim empowerment movements such as #MeToo are likely to result from an increase in patient lawsuits, medical board disciplinary actions, and criminal actions for real or perceived physician sexual misconduct. Public pressure is also likely to result in physicians being held to higher professional boundary standards than they might have been in the past. For example, the Federation of State Medical Boards, or the FSMB, updated its policy statement on sexual misconduct just recently in May 2020, in which it called for shared regulation that includes addressing sexual misconduct through meaningful disciplinary action and law enforcement when required. One of the strategies highlighted as a means to achieving greater regulation is physician reporting of colleague misconduct. Consequently, even those physicians who would not consider engaging in sexual misconduct with a patient must also be able to recognize it in others. A different type of sexual misconduct allegation results from patient misinterpretation of procedural touch. Closed claims analysis indicates that these claims are more likely to be dismissed early in litigation without any indemnity payment when medical record documentation and chaperone use provide evidence that the procedural touch was, in fact, appropriate. Strategies are provided to help reduce the risk of misunderstandings and increase defensibility when these allegations are made. Now let's take a look at a case study based on a closed claim. In this case, a 30-year-old woman with very large breast implants presented to a family practitioner for chronic chest pain. After hearing the patient's description of symptoms, the family practitioner suspected the patient's chest pain was caused by costochondritis, an inflammation of the cartilage that connects a rib to the sternum. He explained, however, that in order to evaluate her, she would need to be completely disrobed from above the waist. When she'd removed her shirt and bra, he attempted to evaluate her costosternal and costochondral joints, but had difficulty doing so because of the patient's breasts. The family practitioner then asked the patient to hold her breasts out of the way so he could complete his evaluation. He ultimately determined that the patient did not have costochondritis and concluded the patient's chest discomfort was most likely due to anxiety. He shared his diagnosis and a treatment plan with the patient and turned to his computer to enter his findings in her medical record while she dressed in the room. He did not request or offer a chaperone prior to the evaluation. He did not offer to leave the room while the patient disrobed. He didn't offer her a gown, and he also did not allow the patient to dress privately after the examination. The patient later sued him, alleging he had handled her breasts for his own sexual gratification. From this case example, you can see there must be a balance between providing an appropriate medical examination, but also accommodating a patient who is sensitive to having her breasts touched. The risks of false allegations of sexual misconduct in this and future situations could be reduced by offering or requiring a chaperone, avoiding unnecessary contact with a patient's breasts, explaining the necessity of breast contact during appropriately performing exams, and otherwise supporting patient modesty. This case study is just one example of how the physician did not appreciate the gravity of the sensitive exam and blurred the boundaries with the patient, which resulted in a lawsuit and added time defending such allegations. Now let's turn to some guidance from the AMA as to how this situation could have been handled differently. Assuming nothing inappropriate happened, this case was ultimately dismissed. It is, however, an excellent example of why physicians should heed the advice of the AMA Code of Ethics, Opinion 1.2.4, on the issue of respecting patient dignity and the use of chaperones. Efforts to provide a comfortable and considerate atmosphere for the patient and the physician are part of respecting patients' dignity. These efforts may include providing appropriate gowns, private facilities for undressing, sensitive use of draping, and clearly explaining various components of the physical examination. They also include having chaperones available. Having chaperones present can also help prevent misunderstandings between a patient and physician. Physicians should first adopt a policy that patients are free to request a chaperone and ensure that policy is communicated to patients. Always honor a patient's request to have a chaperone present. Have an authorized member of the healthcare team serve as a chaperone. Physicians should establish clear expectations that chaperones will uphold professional standards of privacy and confidentiality. In general, use a chaperone even when a patient's trusted companion is present. Provide opportunity for private conversation with the patient without the chaperone present. Physicians should minimize inquiries or history taking of a sensitive nature during a chaperoned examination. The main takeaways from this AMA code are: first, have a policy for chaperones. Ensure that you have a designated staff member to serve as that chaperone. Use them regardless of if the patient's trusted companion is present. Even in the Larry Nassar case, there were parents in the room with the minor patients who were receiving treatment, but it was conducted in a way that even the parents couldn't see the abuse that was taking place right in front of them. Always consider having a private conversation with only the patient after the exam is complete. Because we're seeing an increase in news stories featuring allegations of inappropriate conduct lodged against individuals in a variety of professional settings, One way for a physician to guard against similar claims is by implementing that chaperone policy for all sensitive exams. Let's take a look at one of our 2 minutes What's the Risk videos entitled Professionalism in Medical Examinations, where our colleague explains how a chaperone policy not only respects the patient's dignity, but also serves as a valuable tool in the defense of a professional liability claim.
Hi, I'm William Ashley, Senior Risk Resource Advisor with ProAssurance. Maintaining appropriate boundaries in the physician-patient relationship is an essential means of fostering trust with the patient. Patients come to your practice with a variety of social and cultural backgrounds and sensitivities, and a physician must take steps to respect the patient's dignity. One practical strategy to establish and demonstrate appropriate professional boundaries is to implement a chaperone policy in your practice. In fact, many state licensing bodies already require the use of a chaperone during sensitive physical exams. A chaperone is just a member of your staff designated to serve as an observer during an intimate physical examination of a patient. A physician should always offer a chaperone before this kind of physical exam, regardless of whether the physician and the patient are of the same gender. If a patient brings a companion to an appointment, don't rely on this individual to serve as a chaperone. The companion may not have the medical training necessary to know which aspects of the physical examination are appropriate. Before undertaking a physical examination, describe what the exam entails, explain why you use a chaperone, and ask for the patient's consent to the chaperone's presence. Always note the patient's consent in the chart, along with an entry identifying which member of your staff observed the examination. If a patient refuses the presence of a chaperone, enter a note in the chart indicating that a chaperone was available and that the patient refused. In addition to respecting your patient's dignity, a chaperone policy can benefit a physician in the event of a malpractice suit. If a dispute arises about what transpired in an interaction between the physician and the patient, a chaperone can serve as a valuable corroborating witness. Develop a chaperone policy that sets forth a chaperone's duties and defines the circumstances when a chaperone will be present. Train staff members serving as chaperones where to stand in the exam room and what to look for with sensitive exams you may perform. Abiding by a chaperone policy demonstrates professionalism to the patient and can protect the physician from unfounded claims of inappropriate conduct.
All right, so let's take a look at some risk reduction strategies when it comes to patient care in sensitive exams. First, use an individualized approach to intimate examinations, considering the patient's vulnerability and potential apprehension, fear, and even possible embarrassment. Communicate the office chaperone policy to patients who are asked to disrobe. Explain the purpose of disrobing, when doing so may not be obvious to a layperson. One of my colleagues and close friends shared a story that, although it's funny, it depicts what patients sometimes go through trying to navigate medical appointments as non-clinicians. She was due for her first mammogram, went into the room where she was instructed to disrobe and put on a paper vest for the exam. She misunderstood and removed all of her clothing, which was quite the shock for the mammography tech, who quickly told her as she only needed to undress from the waist up and to please put her underwear and pants back on, and she would return shortly for the mammography. Do not ask the patient to disrobe in your presence, just as was done in our case example study. That is inappropriate. Give clear instructions about which articles of clothing the patient should remove and which should remain on. Provide the patient with a gown, sheet, and/or other appropriate apparel. Offer a gown that will provide appropriate coverage, not too big, not too small, and direct the patient to use the fasteners or ties to close the gown. When a reasonable time has passed for the patient to disrobe and drape, knock on the exam room door. Announce your re-entry into the examination room and wait for a response. You also want to introduce the chaperone, explain their name, their role, and what their purpose is in the examination room. Be alert to possible misunderstandings. Tell patients what they should do after dressing, and document the time when the chaperone was present during the examination, including the chaperone's full name, job title, as chaperones can vary from day to day with vacations, time away, and you cannot assume it's always going to be the same person in your office practice. Here's some general listed requirements to consider, including in your own chaperone policy. First, you want to set forth chaperone's duties. Also consider defining the circumstances when a chaperone will be offered. The key is the required documentation in the medical record to include not only the patient's consent and who the staff member observer is that's present, but also if a patient were to refuse a chaperone. Now let's take a look at our ProAssurance sample OBGYN form. This sample chaperone policy is from ProAssurance and again is used directly towards OBGYNs, as those are a specialty required for the most part to have chaperones available. This form is a good starting place for those of you who want to develop your own policy and gives you some framework to expound upon. One area to point out is the role and responsibilities of the said chaperone. As with any policy document, and the education of the select staff members who will be serving in the role in their employee file is always important. Although this sample form specifies female gender for the chaperone, I think it is appropriate to draft these documents in a more gender neutral way to be sure it covers all patients, regardless of gender or gender identification. Allowing the patient to share preferences is a good way to address questions that might arise. So again, this is a starting place if you do not currently have a chaperone policy, but are looking for some beginning wording as to how to craft your own practices policy. So how can you prepare for an allegation of sexual misconduct, and how can risk management proactively help you? If a patient makes an allegation of sexual misconduct, the best response is one that is thoughtful and organized. Such a response is best achieved by following a policy that includes guidance for reporting the allegation, documenting the event and process, and conducting the investigation. Consider the following recommendations and risk reduction strategies. If there's an incident, first determine if the patient needs any additional medical care and either refer the patient or offer care from a physician other than the person accused. Refer the patient to the emergency department for a sexual assault examination if and when appropriate. Assure the patient that his or her allegations are being taken seriously and that an appropriate investigation will occur. Document the allegations in an incident report. You want to keep this documentation separate from the physician's documentation in the medical record as it relates to medical care. Include the patient's statement, starting with a statement such as the patient alleges, and then include the facts that are offered. Do not include subjective feelings or beliefs, speculation or blame, references to investigation results or event analysis, or references to communications with malpractice carrier or attorney. You do, however, want to notify the claims department immediately to determine what coverage may be available. You also want to investigate the allegations pursuant to the practice policies and protocols. Analyze the allegations to prevent recurrence. Limit communications about the allegations in a manner consistent with HIPAA and state privacy laws. You also want to consider disciplining any accused clinicians and staff when investigation reveals that there were policy or protocol violations. Provide the accused individuals with due process in relation to disciplinary actions. Although practices and physicians may not be able to prevent complaints or allegations of inappropriate behavior, providing actionable steps to incorporate into patient care can mitigate the potential risks should an allegation arise that a physician crossed the line in an exam, as well as bolstering testimony with the presence of a chaperone. Having a chaperone policy as well as a policy for responding to any allegations are just two ways to protect your practice. Consider training your staff on your policies and ensuring they communicate with patients about their options. Now we're going to move on to our next topic under boundaries with patients. Prescribing of controlled substances is another area where practices and physicians can have liability exposures when treating patients. Let's again start this topic session with another audience participation polling question. This question is, when prescribing controlled substances, do you use a pain contract? Choices can be yes, I always have a pain contract if I'm prescribing controlled substances. Sometimes I do. No, I don't use a pain contract, or not applicable because I do not prescribe controlled substances. So we'll give you a minute to tabulate your responses and get those clicked, and then we'll share some results. see from these results, about a third of you say, hey, I don't prescribe these, and that's why we are only making this a small portion of this topic. But from those that do, it looks like about a quarter, 24%, are always using these paying contracts. There's 14% that say sometimes, and then about 25% that say there's no use, that they currently do not use a paying contract when prescribing controlled substances. So let's now take a look at a closed claim case study. In this case study, a family medicine physician prescribed narcotics to a 58-year-old female while the patient was also being treated by a pain management physician. The patient terminated by a pain management physician because she was filling forged prescriptions. Following that patient termination from pain management, the family medicine physician increased the patient's narcotic prescriptions. The patient ultimately died as a result of multiple drug intoxication. The autopsy showed that she was positive for benzos, for muscle relaxers, and also opiates. There's a few takeaways where this physician fell short of appropriate care. First, he never checked the drug monitoring database to see the prescriptions the patient was receiving from other providers, where she was filling them, or even how often. Although this report should not be included in the medical records for fear it could be reproduced in a medical records request, physicians should document in the medical record when they consult this database on behalf of a patient. The family medicine physician also did not conduct a toxicology screen on the patient to see if she was taking the prescribed medications appropriately without the addition of any other substances. The defendant also did not investigate the circumstances of the patient's discharge from pain management. He somehow took the patient's word that she herself fired pain management physician, not the other way around. In any medical malpractice lawsuit, the standard of care will be determined by experts both for and against the physician. In this case, the plaintiff's expert testified the physician breached the standard of care with the following allegations. The prescription of medications were in a quantity, dose, and classification that's function was to depress the central nervous system. There's an allegation that it was a failure to monitor pain medications prescribed, a failure to refer to other specialties, maybe neurology or psychiatry, and ultimately this case settled due to the number of shortcomings laid out before you. So what can you learn from this case example? In the initial visit with a patient, you will always take a history and physical to show as a baseline for any treatment recommendations. First, you want to document the nature and intensity of pain as presented at that very first visit. You would also want to review any current or past diagnostic studies and treatments that the patient completed with other providers. There may be some underlying coexisting diseases that account for the severity of pain, and so those may need to be identified. Have the patient describe the effect of pain on his or her physical and psychological functioning. What can he or she do or not do? What are some of their activities of daily living that they wish they could? This is also an appropriate time to do a baseline screening for substance abuse, depression, and also suicide. As was not done in the case example, you may want to consider reviewing the PDMP if available and documenting in your initial history. After the initial history and physical, you will then need to determine how to manage this patient during your initial treatment at the first visit as well as subsequent visits. You want to have consistent documentation of urine screen results, ensuring the patient knows they might be financially responsible for such tests. You want to have descriptive qualifiers like aching, dull, sharp that need to be included in your documentation. You also want to be clear as to identification of pain locations and note them in the record. Pain scales like numbers 1 to 5 or 1 to 10, even the pictorial faces as to happy or sad should be assessed at every visit for consistency. Also documenting the impacts on activities of daily living, such as what the patient wishes they could do in his or her daily life, but are unable to complete due to pain. As you continue through the course of treating a patient with controlled substances, you should also consider how you will measure success. Identification of objectives to measure treatment success need to be determined, such as what activities of daily living would the patient like to be able to accomplish that they cannot currently do. For example, they might want to sleep for 6 hours consistently, or be able to walk to the mailbox to check their mail each day, maybe even light exercise 3 times a week for 20 minutes. Documenting any diagnostic studies or consultations that you recommend or plan to take place, any adjustments in drug therapy, should all be included in the record. One of the most important considerations is to also memorialize an informed consent discussion in the form of a pain contract with any patient receiving controlled substances under your prescription. Continue to have regularly scheduled follow-up appointments where you bring the patient into your office in order to evaluate and continue your ongoing treatment. Once you've determined that you will continue to prescribe controlled substances to a patient, it's important to keep in mind some of the key risk reduction strategies. You want to establish expectations and consequences before prescribing controlled substances, such as no prescriptions from other physicians, refills only at scheduled appointments, no replacement prescriptions, no illicit drug use, and using medications only as directed. We've recently seen claims where a physician bends the rules for patients who are maybe traveling for work, going out of town, or have other explainable excuses for needing those prescriptions early, but these should be evaluated very closely and used only as a last resort. You may want to subject patients to random drug screening, while again considering that the patient may have to self-pay as insurance may not cover them. You could also consider randomized pill counts, and that can be a way to keep patients accountable, but they're not always a foolproof way, as patients can access pills for count purposes, only such as renting them, and these often take up precious office visit time that can be better utilized in other ways. One of the most important protections is to memorialize expectations in a controlled substance agreement. Obtain patient acknowledgement that failure to meet expectations results in termination of the treatment relationship or at least treatment with certain medications. ProAssurance does not have a sample form for patient contracts or agreements, but I do want to leave you with one of the best online resources that I've come across. It's a sample agreement from the National Institute of Health, NIH. I've got the link down at the bottom, and we'll be sure to include this in handouts. This used to be on drugabuse.org, if you're familiar with that one. It's a lengthy document. This is only one of the pages to include, but I wanted to highlight just a few provisions of note that you'll see as potential clauses to include with any agreement you draft for patients, and really having them agree to it, that they're responsible for their medicine. They're not going to increase the medicine without talking to a doctor first. It's not going to be replaced if I lose it, if it's stolen, if I somehow need it sooner. I'm also going to agree to keep my appointments, whether they be with my doctor or any other referral sources, such as physical therapy or substance abuse treatment. I'll also bring my pill bottles and have those there for counting if needed, or as a backup plan for the physician or clinician. And I also agree to give blood or urine samples if asked to do a drug test to ensure that proper medication is in the patient's blood or urine, and nothing in addition to those substances in which the physician is aware the patient is currently taking. Now, I don't want to spend too much time on this topic, as I know, obviously, from our polling questions, that not every physician prescribes controlled substances. So I want to leave you with some additional resources if this is an area of known exposure for you as a physician or for your practice. We do have 2 additional ProAssurance seminars on this topic, as well as you'll see a couple of other links, one from the American Academy of Pain Medicine. They've got a number of resources for practices, patient education tools, and then obviously the National Institute on Drug Abuse has that sample patient agreement form. I encourage you to check out those links. But if you are needing more specific education, we do have 2 one-hour-long programs with ProAssurance. There's opioid prescribing, keeping patients safe, and prescribing controlled substances, what a practice needs to know from a DEA perspective. And these are online programs that will be available to you. Now let's close out this boundaries section with patients with a tried and true topic of treating friends and family. Many of you have entered the field of medicine to help others, and at times you can even help those closest to you with their medical care decisions. But this is not without risk. We recognize that within medical institutions, and especially small towns or rural areas, physicians often socialize with the same people with whom they provide care, blurring those lines between friend and patient. There's a distinction between a friend or a colleague who establishes care as a patient in the practice and for whom the physician keeps formal medical records on. versus a friend or neighbor who only interacts with the physician socially. Some physicians practice in settings in which there is no other physician to offer care. A surgeon in a rural area may be the only option for a family member who needs urgent or emergent surgery. And in such cases, care would be ethically appropriate. Our ethical concerns center around the provision of informal and undocumented care to those friends and family members, care outside the usual medical encounter. So why may a patient want to seek treatment from friend or family member who's a physician? First and foremost, I'd say it's convenience. Often you're available outside typical office hours. It's usually communicated over the phone or text message, maybe even an email. So it's quick, it's easy, and it's a fairly quick response back from the physician. Another factor might be cost. With high deductible plans, it's going to be a lot cheaper to just have a prescription called in by a friend than having to pay the expenses of having an office visit and possibly other testing to determine what's going on from a treatment standpoint. There could also be that genuine belief in the quality of care being higher for someone you know. So why would a physician provide treatment to a friend or family member who requests it? First and foremost, I think physicians got into the practice of medicine often for the desire to help others and wanting to make things better, wanting to help those they care about and extending that to those they maybe don't know on a personal level. But there's also, on the flip side, some pressure. There's pressure to fulfill those expectations. When you're asked by a friend or family member to go outside of your scope or write a prescription, it can be difficult in those situations to say no. Being in that dual role of both a friend and family member and a medical physician may create some conflicts of interest. You may get requests from friends and family that may affect your treatment objectivity and even your consent process, as the friend or family member may not give you all the details of his or her condition, and you may not be able to see the whole clinical picture. So now let's take a look at another audience response question. Here's our next poll. I want you to read this question very carefully and make sure you note it says, have you ever written a prescription for a friend or family member? So not have you ever treated a friend or family member, but have you ever written a prescription for a friend or family member? Yes or no? How are we going to shake out? All right, 79%. That's higher than I anticipated. Excellent. Hey, 79% of you said yes. Is that the right answer? Well, we'll take a minute and look at it. But we got about, like I said, about 80% saying yes and 20% saying no. All right. So I phrase this polling question in this manner because I find physicians are more likely to treat a family member or friend as a regular patient if they're seeing them in their practice and creating a medical record. Often we see prescriptions being signed when there's no true physician-patient relationship, but even that can carry some liability. Now let's take a look at a case study example where an employee's husband was treated by a colleague where it was more than just a prescription written, but true medical treatment and surgery were performed in a less than optimal way with minimal documentation. Here are the facts of that closed claim study. Although this one's a bit more medical treatment than just writing that prescription, it falls squarely within treating friends and family. So the facts are a 49-year-old male, 5'11", 246 pounds, sees general surgeon with complaints of a cyst on his neck. He's got a history of headaches and blurred vision. The patient's wife is an employee of the wound care center that employs this surgeon where the patient went to go receive medical treatment. The visit with the surgeon was initiated by the wife, who asked the surgeon to, quote, just take a look at my husband. He's not able to get in with his primary care physician for a couple of weeks, and so the surgeon performs the exam kind of as a favor to his coworker and recommends that the cyst does need to be excised. So the excision is completed. Patient is discharged. 1 week later, however, the patient calls and he complains that he's got an inability to elevate his shoulder. The surgeon recommends seeing a neurosurgeon immediately to investigate possible nerve injury and even gets the patient an appointment to see a neurosurgeon the following day. Patient delays the visit to the neurosurgeon to accommodate his own schedule, but he eventually is diagnosed with a severe spinal accessory nerve injury at C5 level. A neurosurgeon performs an external neuroplasty with sural nerve graft from his leg the left spinal accessory nerve. Postoperatively, the patient claims he has limited ability to raise his arm and neuropathy at the nerve harvesting site. Next comes a lawsuit. It's filed against the general surgeon who removed the cyst. In this case, the plaintiff's expert against the surgeon said that he negligently severed the nerves near the cyst and underestimated the complexity of the procedure. Now, on the flip side, the defense expert said he met the standard of care, but was even critical and said the physician really should have documented this complex procedure in greater detail. The biggest issue in the defense of this case was that there was no informed consent documentation regarding the surgical procedure. Because the patient did not have a typical medical record with this surgeon, given the difficult facts in the case, the ultimate decision was again made to settle. So let's take a look at some of the takeaway lessons from this particular case example. The surgeon performed the cyst excision as a favor to the coworker. There was no documentation of consent or that the patient even appreciated the risks associated with this procedure. Because of this lack of documentation, it became very difficult to defend whether or not the surgeon met the standard of care. So now let's hear from Dr. Dallas in another one of our 2-minute What's the Risk video series as to how physicians should consider handling patient friendships and distractions when providing medical care.
When you're taking care of patients, as much as you'd like to be friends with your patients, this is not a friendship. Right? And despite the fact that you may sometimes feel pressured to develop friendships with your patients, you have to bear in mind that these relationships should be separate and it should be very clear. You know, when I see patients in the office, a lot of times they come in and because we may have been doing something in the community, we may know other people in common, they want to make the visit a social interaction. Somebody asks you a question about a vacation trip or where did you last travel, right? And you get to talking about it and forgot what you were focusing on a moment before. Or you may get to talking, you would have consumed a considerable amount of time. You have 4 other patients waiting for you, and now you want to rush out, but you didn't go over the lab results. Right? Because in your head, the clock is ticking about the next patient who's waiting, and you do not want them to be upset. It's unintentional, but you've already used up a considerable amount of time. Now, the patient, 4 weeks later, 5 weeks later, wouldn't remember that that was part of the issue or the dynamic that was taking place on that day. I have a sign in my office rooms that says, if you distract me, I may make a mistake. And if I make a mistake, you may not like it. Right? I do not want to be distracted. So let's leave the social interactions and beyond the hi, how are you doing today? Beyond that, let's leave that for outside of the exam room.
All right, so the American Medical Association cautions against treatment of yourself, but also family members, unless they fall within a reasonable exception, like an emergency or isolated setting, or short-term minor problems, such as with our polling example of writing a quick prescription. That may or may not be seen as obviously establishing a physician-patient relationship, but it's something to consider before you sign that prescription. What could this implicate and how could it possibly impact you as a professional? So even specialty societies like the American College of Physicians and the American Academy of Pediatrics also caution against the treatment of close friends. When treating family members, consider the following. Recognize patients' reluctance to share information or submit to an examination. And that's a big one. You want to be sure that you're getting the full clinical picture with whoever you're treating, whether they're a family member or not, and they might not feel as comfortable doing so because they know you personally. Identify potential risks associated with prescribing for family members or friends. You want to be sure that you've got consistent documentation and that you're also communicating with any other primary care physician who's involved in the treatment of that friend or family member. You want to acknowledge the effect of one relationship on the other, and adhering to your own scope of practice and appreciate the risk of going beyond your typical treatment for a patient who's a family member or friend. I feel like I get this question a good bit regarding the legal implications of treating someone outside of your scope. And that's what can be difficult when it's not a clearly defined issue. There might be, again, that reluctance to share information or submit to the exam, especially from a medical history or personal issue standpoint. There's also going to be some prescription concerns, as we pointed out in the section before, because you do see patient name and physician name in the PDMP, and you don't want it to seem as if you're prescribing, especially any type of controlled substance for a friend or family member. That's typically seen as very inappropriate and should be very much guarded against in very, very specific circumstances where that would be acceptable. From a malpractice standpoint, physicians create a physician-patient relationship with family members when they undertake the treatment of them. Like with any other physician-patient relationship, that duty of care continues until the relationship ends. Unlike usual patients, after the physician-patient relationship ends, the family relationship must still continue, and that can really create some challenges for both the patient and the physician. One of our jobs, and honestly one of my favorite parts of how I interact with insureds, is on our risk management helpline. We offer this service for physicians or practices to call us when they have a question. And I recently took a phone call from a physician who was asked by her daughter's school to write a standing order for a couple of EpiPens. This doesn't come without risks, as the physician will not be on site to maintain the pens or administer them, and may not even be able to ensure proper storage of these EpiPens. I gave some advice and left the ultimate decision to the physician. However, I realized this is just another example of a boundary issue and how they can come from other external parties, not just friends and family, but maybe your workplace or schools. This situation comes with a host of potential risks, but I also appreciate that it can be difficult to decline for the sake of the relationship, especially with somewhere like a school or work environment. So keep in mind, boundaries in your personal life can easily be pushed when they intersect with your professional life. Once you acknowledge the added exposure, you can act in a way to mitigate the risk as much as possible. Now let's switch gears a bit into another area of boundaries, and those are with other providers, whether you're referring a patient to a colleague or a specialist, or even coordinating continued care through good handoff communications. So let's take a look at our one last polling question for tonight. This question is, how often do you interact with physicians outside your practice regarding patient care? So how frequently are you working with other physicians, outside of those within your own employment setting? Always, sometimes, or never? All right, so we've got another kind of mixed bag. So we see sometimes. So about 2/3 of our participants tonight say they sometimes interact with others, 20% saying always, and a few said 13% saying never. So I just kind of like to have an idea as to who our audience is and ways in which we can make sure to address this topic in a way that relates to as many of our learners and attendants as possible. All right, so let's take a look at a closed claim case study example. In this case, a 25-year-old female presents to a family physician for OB care at 13 weeks pregnant. The family practitioner suspects twins and refers the patient to an OB for an ultrasound at 17 weeks. The ultrasound was performed at 20 weeks by the OB, reveals it's a dichorionic twin pregnancy. So for those of you that are not OBs, dichorionic would be the least risky of twin pregnancies. The other two types, monochorionic that are diamniotic or monochorionic monoamniotic, are the other various types of twin pregnancies. With dichorionic, the twins would be kind of in separate gestational sacs and have separate placentas. Monochorionic would be in one gestational sac and could either have separate or shared amnions. For the mono, so monochorionic, monoamniotic is the riskiest for twins because of twin-to-twin transfusion, as it's only one chorion and both twins sharing that amniotic sac. Another way to think about it is an apartment building. In dichorionic twins, they would have totally separate apartments in the same building. In monochorionic diamnionic, they would be in the same apartment, but they'd have separate bedrooms. With mono, they'd be sharing a room. On a personal note, I actually had monochorionic diamniotic twins, so the risks are very different depending on the type of twin pregnancy, and that's something that needs to be determined as soon as possible to make sure that there's proper monitoring of the twins and throughout the pregnancy. So moving on into the facts, the patient continues prenatal visits with the family practitioner and ultrasounds by the OB. So they're sharing care of this patient. Subsequent ultrasounds don't really address the type of twin pregnancy, kind of just went with it being dichorionic, diamniotic. And the patient's admitted to the hospital for some preterm contractions at 33 weeks. Both the family practitioner and the OB evaluate the patient, issue orders, and even write discharge summaries while the patient's in the hospital. She comes back to the same hospital at 38 weeks in labor. Family practitioner starts to notice some decelerations on the fetal monitoring strips for twin B and pages the OB for a C-section. After the C-section is complete, twin B is transferred to another hospital with a very tough diagnosis of respiratory failure, cardiac arrest, hypoglycemia, and presumed to be septic. Pathology report on the placenta and a rereading of that initial 20-week ultrasound shows the pregnancy was diamniotic, but monochorionic, not dichorionic. So basically, the patient ultimately sues the family practitioner and the OB in this lawsuit. This case had a host of criticisms regarding the coordination of care, and there were solid defenses for both sides. This case revolved really around the adverse interests and finger pointing, where the family practitioner said it was the OB's fault, OB said it was family practitioner, and kind of each one was saying the other physician was to blame. So in this case example, what was missing? Well, coordination of care. There was no confirmation of the scope of care for either physician. They were sharing the duties without really delineating who was responsible for what. They also didn't have specific communication between each other. There were no specific letters or phone calls documented. There was no documentation of the scope of care, no formal referral letter from family practitioners sending the patient formally to the OB, or even references in the patient chart. So in these kinds of situations, you really want to think about how you can best coordinate care and document it in your record. You want to consider mnemonic devices like standardization of SBAR or IPASS. You want to use referral letters and consultation reports to document those expectations. And you really want to consider raising the level of communication to clarify more complex manners. If it's too complex to describe in a written documentation or communication, feel free to pick up the phone and call the other provider. Having that two-way communication where you're both treating the patient in the most harmonious way is going to be best for all providers involved as well as the patient. So when it comes to care coordination, sharing relevant patient-specific information is really the best way to organize appropriate care. Physicians and other practitioners who are concurrently caring for a patient really need to consider how best to manage the care coordination. You can kind of compare it to handoff communication at shift change or in a hospital setting, sharing that relevant patient-specific information to organize appropriate care from the get-go. Transferring from one physician to another physician or practitioner can be very difficult, and there's concerns from both sides that there might be ineffective care coordination and handoff communication because oftentimes there are different expectations. There's maybe incorrect or insufficient information, and there can also be adverse or unexpected outcomes, and it can be very difficult to document those situations when you don't have good coordination of care and handoff communication so you know what to expect and how best to treat the patient. So as we conclude this seminar tonight, I challenge each of you to think about areas of boundaries with your patients and other physicians and identify an area of improvement with at least one actionable item. Maybe it's enacting a chaperone policy or implementing a pain contract when you prescribe a controlled substance. It might be thinking twice before writing that quick antibiotic for a neighbor or making an extra phone call to a co-treater to be sure that you have proper patient management on your end. Any of these items not only protect you as a physician in the event there's a bad outcome, but it also sets up your patients for success when expectations are clearly outlined and you are mindful of your professional, ethical, and personal boundaries.